Albensi. I'm your Journal Club host. We're broadcasting live from St. Boniface Hospital today. Today, it's my pleasure to introduce to you Dr. Mandana Modirrousta. Dr. Modirrousta is an associate professor here at the University of Manitoba in the Department of Psychiatry. And she's also a principal investigator at our hospital at the St. Boniface Hospital Research Center. She completed her residency in psychiatry at the University of Manitoba in 2012. And that was before pursuing a fellowship in clinical neuropsychiatry at the Massachusetts General Hospital at Harvard Medical School. Prior to her residency, Mandana earned a PhD in neuroscience from the Montreal Neurological Institute at McGill University and completed postdoctoral training in cognitive neuroscience and behavioral neurology there as well. I think that's right, isn't it?
Neuropsychiatry and behavioral neurology.
Okay.
Yeah, that's the name of the fellowship. Yeah.
Okay. And she is certified in the subspecialties of behavioral neurology and neuropsychiatry by the United Council of Neurologic Subspecialties. And she's also the director of the Neuromodulation and Neuropsychiatry unit here at the St. Boniface Hospital, where she uses TMS, transcranial magnetic stimulation, to study brain and behavior. Her research interests include understanding mechanisms of obsessive compulsive disorder and also frontal temporal lobe neurocognitive disorders. And today, of course, she's going to be talking about Lewy body dementia and the Lewy Body Consortium. So welcome, Dr. Modirrousta.
Thank you, Ben.
And don't forget
good afternoon, everyone. Thank you for joining today for this Journal Club. It's a pleasure for me to present this paper on diagnosis and management of dementia with Lewy bodies. This is the report of the fourth consensus report of dementia with Lewy Body Consortium published in 2017. Sorry, I'm a little bit also distracted to make sure that I admit everyone joining. So just maybe the first few minutes. So the reason I like this paper to present, one of the reasons was it's clear example for translational research, although it took from the last consortium report, which was 2005, it's been more than 10 years, almost 12 years that they published the fourth report for diagnosis of dementia with Lewy body. So it took more than 10 years to incorporate research finding into our clinical day-to-day approach of patients with dementia and dementia with Lewy body. And so we are going to go over some of those changes, which include biomarkers that could be utilized in our diagnostic approach. So as I said, the last one, the third report was published in 2005, and this is 2017. And okay. So again, being a clinician at the same time and being a researcher, I could see the burden on the healthcare system when we misdiagnose patients, including patients with dementia, or when we underdiagnose those people. For example, patients with dementia with Lewy body, one of their core clinical features is fluctuation in cognition. And I remember at least 3 examples of those patients being admitted in hospital for months, and they considered their presentation as delirium. And this is particularly more confusing because a lot of time their first dementia symptom, patients with dementia with Lewy body, is not memory problem. And the general concept that is patients with dementia should have memory problems. So their diagnosis will be delayed. And before we go to the updated clinical diagnosis, also I want to mention that with dementia with Lewy body, in contrast to Alzheimer's, there is no specific assessment, validated assessment batteries that could be used to do cognitive tests. But what we do know is they, especially at the early stages, they do have disproportionate cognitive deficit in the test of executive function, attention, and visual processing. And a lot of time, relatively, the memory and naming are intact at the early stages. So this is the revised clinical diagnosis. You see the table. So in general, the main change was the addition of indicative and supportive biomarkers that has been formed based on the research and looking at the sensitivity of those biomarkers and specificity. And if they had high specificity, they were put under the indicative biomarkers, and those with less specific biomarkers for dementia with the Lewy bodies, they were put under supportive biomarkers. So starting from the clinical symptoms, so what we have here are, and then we also discuss later how we make our diagnosis based on this. We have core clinical features that are more specific for patients with dementia with Lewy body. Before that, again, we should ensure that there is a diagnosis of dementia, that the deficit is not due to other conditions, and it's progressive cognitive decline. And we also can see that kind of a lot of time that disproportionate cognitive deficit in executive function area relative to memory and naming. So assuming that that patient has that condition, then we have, based on the new diagnosis criteria, we have 4 core clinical features. The first one is a fluctuation in cognition. And I would say that, again, talking with a lot of caregivers of patients, unfortunately, the history they provide to us has a high false positivity, because we know that patients with dementia, they have lucid moments and they have worse moments. So it's really difficult to ask this question. But what we see in patients with dementia with Lewy body is delirium-like fluctuation in cognition. They become so inattentive, incoherent speech, staring, zoning out. Sometimes we might wonder it's seizure, for example, infection. So the fluctuation in cognition should be very prominent. Then a second core feature is visual hallucination, recurrent visual, well-formed hallucinations, and in terms of the people's, animals, and it's seen in up to 80% of people with this type of dementia. And the third one is the cardinal features of Parkinsonism. By that I mean bradykinesia and resting tremor or rigidity. And this is also seen in up to 85% of people with dementia with Lewy body. And the last one is REM sleep behavior disorder. And this is like people acting out their violent dream. And they can even, punch their partner, and like it's quite obvious if you get the history, ask for the history. So, and then after that, the change for supportive clinical feature, the main 2 changes were adding hyposmia, reduced sense of smell, as well as hypersomnia. The rest, again, the reason we call it supportive, because they lack specificity in terms of diagnosis for DLB. And the rest, as you can see here, are, for example, severe sensitivity to antipsychotics. Again, this is a little bit, this is not a core clinical feature, but again, it is misused in our clinical approach of patients with dementia. And if someone, for example, not having this neuroleptic sensitivity, they say, oh, it shouldn't be dementia with Lewy body, whereas this is only a supportive feature. So we really have to focus on the core clinical features. And other examples are, again, constipation, urinary incontinence, postural instability is a symptom of Parkinson's, but again, is not the cardinal symptom of Parkinson's. So that if they have postural instability, could be supportive clinical feature. And then again, the main change in the fourth report is biomarkers. And although we still do not have a direct biomarker as an evidence of Lewy body related pathology, but there are other indirect biomarkers that could be used in our clinical diagnosis approach. And so the indicative biomarkers, so we discussed this later on again. If we have one or more of those indicative biomarkers plus one or more of core feature, we consider, we make this diagnosis of probable dementia with Lewy body. If there is no core clinical feature, but at least one of those indicative biomarkers are present, then it would be possible dementia with Lewy body. So they mentioned that we should not make this diagnosis in the absence of any core clinical feature, except in the text they explain about REM sleep behavioral disorder confirmed by sleep study, that because of its high predictive value, it could be also, it might, in the presence of just dementia and no core clinical feature, is sufficient to make the diagnosis of probable dementia with Lewy body. And so the first one, the first one again is one of the first indicative biomarker is reduced dopamine transporter uptake in the basal ganglia, and either in PET, if you see that in PET or SPECT, this has up to 78% sensitivity and 90% specificity for the diagnosis. And although normal uptake has been reported in autopsy confirmed dementia with Lewy body, either because there was minimal brainstem involvement and limited neuronal loss, or there was a balanced loss of dopamine across the whole stratum rather than just caudate. So if you look at the image here, the top panel is just the MRI, a comparison of the same patients that we see the SPECT on the panel under that. So Alzheimer's disease, dementia with Lewy body, and normal control. As you see, the medial temporal lobe hippocampus here is clearly atrophied in Alzheimer, but in dementia with Lewy body is relatively preserved and relatively similar to normal control. But when you look at their SPECT, we see again relatively normal uptake in caudate of patients with Alzheimer's and normal control, whereas in dementia with Lewy body, we see the significant reduced uptake in caudate. So this is one of the indicative biomarkers. So the second one is the low uptake in myocardial scintigraphy. So so this is this test looks at the post-ganglionic sympathetic innervation of cardiac muscles, and in patients with dementia with Lewy body, it's been shown that this is reduced. That in fact there is denervation of post-ganglionic sympathetic nerve with 69% sensitivity and 87% specificity. And also, it is a valuable biomarker when you want to distinguish between probable dementia with Lewy body from probable Alzheimer's, 77%. In fact, it has a higher value in discriminating these two if we are dealing with milder cases of dementia. So here's the, again, the figure for scintigraphy. Again, we have Alzheimer, dementia with Lewy body, and normal control. And you see the heart and then the circle part that, again, Alzheimer's is similar to what we see in normal control, whereas we see the reduced sympathetic cardiac innervation in patients with dementia with Lewy body. So the third one is sleep study. If there is confirmed REM sleep in the sleep study without any atonia, this is highly predictive. And again, as I said earlier, it has 90% likelihood of synucleinopathy, and it might be sufficient enough to justify probable dementia with Lewy body diagnosis, or even in the absence of a core clinical feature. So what we see in, normally we see in REM sleep, it's this is a ocular graphy for left and right, and then here are the muscles for submental leg and arm. And during REM sleep, we normally should have muscle atonia, as it is clear in the normal control example here, whereas REM sleep without atonia, we don't see that in EMG. We in fact do not see any atonia happening during REM sleep. Then we move on to the supportive biomarker. Again, as we said, they're supportive because they lack the specificity, but they can still be useful. And then one of them is, we showed that in the MRI, that it's relative preservation of medial temporal lobe structure in MRI or CT, as we saw relative to Alzheimer's. We have hippocampus is relatively not atrophied. Or in FDG PET or SPECT, again, we see generalized low uptake, plus reduced occipital activity, and what we say the singlet island sign in FDG PET. So here, again, we make the image compares Alzheimer's brain, DLB, and normal control, that you see that both dementia with Lewy body and Alzheimer, they have general reduced metabolism, whereas in dementia with Lewy body, we also see reduced metabolism in the occipital lobe, plus again, what they call it, the singlet island sign, that here, when you look at, again, in DLB brain, it's the relatively, it is the metabolism is higher relative to the surrounding structures, whereas in Alzheimer, we see kind of generalized hypometabolism. So this could be another supportive factor. And then the other one, again, the third supportive biomarker is prominent posterior slow wave activity in quantitative EEG with periodic fluctuations in the pre-alpha theta range. So to make the diagnosis, so again, when you see a patient, 2 or more core clinical features with or without any indicative biomarkers, it would be probable DLB, or when we have only one clinical feature, core clinical feature, plus 1 or more indicative biomarker, also we call that probable DLB. And although here they say that probable DLB should not be diagnosed on the basis of biomarkers alone, but in the text it says that confirmation of REM sleep without atonia and dementia could be sufficient to make probable DLB diagnosis. And then the next one is possible dementia with Lewy body. If there is one core clinical feature with no indicative biomarker, or there is at least one indicative biomarker, but there is no core clinical feature. And then they also discuss in what situations that dementia with Lewy body is less likely. If, of course, there is another brain disorder or physical illness that could better explain, or cerebrovascular disease that can better explain the whole clinical presentation, or other types of dementia like corticobasal syndrome, which can explain some of those symptoms. So those diagnoses should be excluded. And if Parkinsonian features are the only core clinical features and they appear first, and the dementia appears years after, then again, that won't be dementia with Lewy body. And then again, clinically, again, this hasn't changed since 2005 report, that clinically the cognitive symptoms in the context of Parkinsonism should either precede the Parkinsonism or be concurrent. And usually the time period that it's assigned and it's been shown to be clinically helpful is 1 year, within 1 year. So in terms of genetic and fluid biomarkers, unfortunately, at this time, there is no genetic testing recommended that could be applied in clinical setting, either for confirmation of the diagnosis or even for predictions. There have been some genes associated with different types of Lewy body syndrome, or the GBA mutations are overrepresented in dementia with Lewy body, but most individuals with dementia with Lewy body do not have them. So at this time, it's not, genetic testing is not recommended for this type of dementia. And then the next, this is more, I guess, the table that they looked at the pathologic finding and the assessment of the likelihood that the pathologic findings are associated with typical dementia with Lewy body. So this is a comparison between, because a lot of time in autopsy cases, we see Alzheimer type pathology, and we also see Lewy bodies and pathology. So for example, here again, this is from the paper in 2005 that in terms of the Lewy bodies, like depending on the numbers, the counts, it could be mild, moderate, the Lewy bodies, severe, very severe. And then also another factor in classification of Lewy body pathology is where they see Lewy bodies. And both together, if, and then here on the top panel is the Alzheimer disease neuropathological finding, according to National Institute on Aging Alzheimer's Association guideline, like stage 0 to 2, for example. If the Alzheimer pathology is at stage 0 to 2, whereas Lewy-related pathology we see diffuse neocortical, so there is high likelihood that the dementia would have been dementia with Lewy body rather than Alzheimer's. And the same type of categorization, let's say again, limbic area, we see in limbic area Lewy body related pathology. Again, Alzheimer pathology is at this stage, then that has high likelihood that the dementia of that person would have been dementia with Lewy body. I think that's the end of this. And then they talked, of course, about the management, which I thought it was maybe relevant for this presentation. And more importantly, there wasn't anything new that could be added to be added value, whereas I found that incorporation of biomarkers in our clinical, day-to-day clinical diagnosis was very interesting. I would say that at least here in Manitoba, I think we really follow this clinical approach, and partly is because we don't have the resources. The simplest one, which is sleep study, in fact, again, if people don't want to pay, then there's a long wait time for that, whereas this could be really helpful diagnostically. The other one, like what we do sometimes, the only thing we have is PET FDG for clinical application, as far as I know. And if you look at the diagnostic table, FDG PET is only a supportive biomarker, not an indicative biomarker. But again, as I said, accurate diagnosis is not only important to further develop disease modifying agents, so for therapeutic purposes, and also they're important for the burden in our healthcare system when we underdiagnose people and we delay the diagnosis or even misdiagnose someone, like that really affects patient quality of life, caregiver, as well as our healthcare system. I think that's it, and I'd be happy to open up for discussion, the session for discussions. Any comment? I'll be more than happy to hear.
That was great, Mandana. I have a couple questions to start off. So, you know, at the the Alzheimer's Association International Conference, I think it was last year, I went, and of course, there were several studies presented that talked about blood biomarkers. And it seems like overall, there's been an improvement in the accuracy and the predictive value of some of these blood biomarkers of dementia. I was just wondering if you could speak to what's happening in that world with regard to Lewy body dementia and blood markers.
Yeah, again, there are two things. One is this paper is published in 2017, and by the time possibly any blood or CSF biomarkers make any validity for diagnosis will be probably another 10 years or so. So this is one thing, but the other part is, as far as I know, that whereas we do have blood biomarkers for Alzheimer's, again, they look at the total tau protein relative to phosphorylated tau and amyloid B, and this seems to be valuable for diagnosis of Alzheimer's. As far as I know, although there have been some studies, but not enough to be considered as a specific test for consideration of its use as a biomarker in dementia with Lewy body. So I know that for Alzheimer's, yes, there have been, and they use it in some centers, but not for dementia with Lewy body, as far as I know.
Okay. And I just have a very good quick question, and then I'll open it up to everyone for other questions. You know, it's interesting that hallucinations are part of this disease process, and I don't really hear people talking about looking for amyloid in the visual cortex. Is that routinely done?
Why amyloid? Why amyloid? But like for with Lewy body?
Well, I guess I really should be more general, and any type of pathological marker. Do people routinely look for these markers in the visual cortex in Lewy body dementia?
Well, the criteria looks like the Lewy body pathology, which would be Lewy bodies and I guess they call Lewy neuritis, like the Lewy body pathology, let's say in general. So if it is widespread in neocortex, then I guess when they say widespread, if you remember here, like here, diffuse neocortical, I think that also includes occipital lobe. Whether or not, that's actually a very interesting question, whether or not those abnormal molecules contribute to visual hallucination as opposed to the dopamine disruption, the disruption in the dopamine system.
Right.
Also.
Okay, very good. Thank you. I see a
Ben,
couple
it's Mark
questions.
Delbijo.
Yeah, go ahead, Mark.
So just two comments. One regarding the blood biomarkers. So if you compare, in an typical Alzheimer case, there's, in the tissue section, there's lots of amyloid and lots of tau. And so it's not surprising that some leaks into the blood, whereas in a typical Lewy body dementia case, as shown on this last, we almost never see what would be classified as very severe. If the histopathology is any reflection, the abnormal protein load is much, much lower in Lewy body dementia than it is in Alzheimer's disease. And so statistically, the likelihood of getting some into blood is lower. Regarding your comment about, or your question about visual hallucinations, we routinely sample the calcarine fissure region, which includes the primary visual cortex. And in Alzheimer cases, we routinely will do a Bilshkovsky stain, at least in that area, but we don't routinely do alpha-synuclein immunostaining in that area. It might be done in some brain bank situations, though.
Okay, thank you for that, Mark. Mandana, I see some questions starting to appear in the chat box. I'll just read one of them, unless Colleen, do you want to read it yourself, or should I just read the question?
Sorry. You can read the question for me.
Okay, so Colleen's asking, does it make a difference if reported REM sleep behavior disorder symptoms are very occasional, like 1 to 2 times per year, or are they more consistent?
Well, what this paper mentioned was it could get better. There might be a history of REM sleep behavior, which a few years before dementia, but then as the dementia progresses, those behaviors might be attenuated. They did not specifically talk about this occasional sporadic once or twice, but it is possible that we hear the history, but not when the person has dementia. This is still valid. Personally, I think if it is just once a year, I doubt the clinical value of that once a year, because anything might make you a little bit agitated at night. So it should be, in my view, fairly persistent. But according to this paper, it is possible that the symptom gets better over years.
Okay. I have another question here from Dr. Guha. So Dr. Guha asks, in terms of Lewy-related pathology, does tau take any role in any tau modifications being observed in terms of patients' brains?
I guess that's probably Dr. Delbijo can answer this better, but my general understanding is synucleinopathy is different from tauopathy. So this is my just general understanding. So I'm not sure again if any tau modification agents could be used for patients, but again, if Dr. Delbijo can help with that. But again, we see overlapping Alzheimer pathology and Lewy body pathology based on the last table 3. But the diagnosis, the ratio is important, I understand.
Yeah, so the pathologies are separate, and so there's no direct hyperphosphorylated tau inclusions in neurons that have alpha-synuclein inclusions, but I agree that we often see a combination of Alzheimer type and Lewy body type degenerative changes coexisting in many of the brains.
Okay, very good. I see a question here from Dr. Bolster at the University of Winnipeg. I'll just repeat the question. Is the density of Lewy bodies in histopathological tissue samples tightly correlated with areas of reduced metabolic activity, such as in FDG PET scanning?
Yeah, that's a very good question. It wasn't anywhere in the paper about that. I don't know. I assume, yeah, maybe, but I don't know the accurate answer again. If it is, they didn't mention the correlation between these two. I don't know the answer.
Thanks.
Any other questions for Dr.
What I
Modi?
know generally, again, based on those interesting autopsy confirmed cases, including, I guess, if Dr. Delbiju remembers, we sent one of our patients, like they wanted for autopsy. The clinical diagnosis is something, the imaging and MRI structural atrophy is another category, and then the autopsy finding is another category. So to my surprise, for example, if a couple of times, including one of my own patient, what we thought clinically is going on with the patient, plus the MRI finding, autopsy did not confirm that. So that's why, like, I guess those criteria are always made based on those prospective studies, and then also those autopsy available brain tissues, and then they retrospectively look at the clinical finding versus and imaging, and then they use that in the clinical diagnosis and specificity and sensitivity of these tests.
Yeah, in the best brain banks, the correlation is about 85%, typically, for broadly speaking, for neurodegenerative diseases.
Okay. Mandana, I have another question about this consortium and the publication. So I guess the paper that you presented was published in 2017. Is this happen in a routine cycle? Do we expect another update in another 2 or 3 years, like every 5 years, or is it just?
Yeah, I think so. And but again, I don't, like, again, the last one was 2005. The one
Right.
before that, I think, was 1998. So I guess
It's a bit sporadic then.
it really depends if researchers do have good questions.
Okay.
If we don't have good question and good research, its eventual clinical application, unfortunately, won't be as straightforward. It all depends on researchers.
Okay.
That's the thing. We do have similar diagnostic consensus for FTD, for example, the variants of FTD, other types of dementia, corticobasal syndrome. Yeah, it's I think it's kind of a common practice. Every a few years they come up with new diagnostic criteria based on their research findings.
Okay, very good. So any other last questions? We still have a few minutes. If not, we'll wrap it up. Any questions from anyone? Well, Mandana, I want to thank you again on behalf of everyone for volunteering to present today. It was really great. And thank you for doing it so close to the holidays. And I just want to remind everyone that we'll post a link to the recording later today in case you join late, or tell your friends that weren't able to join, and we'll post that on LinkedIn and Twitter and all those medias that we use. And we'll also have it on our Manitoba Dementia website along with the paper in case you want to refer to that. So thank you again, Mandana. I really enjoyed that, and I wish everyone happy holidays and to stay safe. Okay, happy New Year to you.
Thank you, everyone.
Okay, thank
Happy
you.
holidays.
Okay, bye-bye now.